Hello, Don here. Welcome to Podiatry Practice Mastery, where we're helping you take your practice to the $1,000,000 mark and beyond in your own personal production. I wanted to start today with a couple of questions I got. As I've been talking about urgent cares, there was a doctor that reached out to me and said, "Hey, doc, how about insurance coverage for your urgent care? How is that working?" And I said, let me check, because I don't know. I just see patients. And so I asked one of my office managers here, and they said, for the most part, when patients make an appointment online, there is a kind of a scrubbing field, meaning it says, we do not take this and this and this insurance, just want you to know that. If you want an appointment, there's a cash pay amount, but otherwise, pretty much don't make the appointment. That's how it is online. If they do it on the phone, same thing. We tell them the insurances we take and we don't take, and then they can choose to see us. If they're in a hurry, sometimes they do see us, and we have a reasonable cash pay amount. It's usually the amount that insurance would pay us. I think for probably a new patient, it might be $150, depending on level. Level 3, maybe level 4 is $200. And then x-rays might be, $50 or something like that. And then any other things that we do would just be kind of a la carte for those patients. So I'm having patients that come in and pay. We've had a few patients that make the appointment and they don't know that we don't take their insurance because, for example, there's something here called Tufts Direct. So we take Tufts, but Tufts Direct is a Medicaid or a Mass Health product, and we don't take that. So they'll come in, there's a little bit of confusion there, so it's not perfect in terms of checking insurance. So this is something that we're learning as we're doing it, but I still think filling up the schedule is worth it with this urgent care model right now. Another question that someone asked me is they said, I want to start using a virtual scribe like you do. What is really necessary for a virtual scribe? So I've talked extensively about Murali. He is my third virtual scribe. We chose virtual versus in person just because our office, our rooms are small, and we didn't, frankly, I didn't want someone's in my space all the time when I'm there. And so what I need for a virtual scribe is a cell phone. So I have a second Samsung cell phone, and we have basically I do a phone call via Microsoft Teams. So Microsoft Teams, the same number, I don't know if you've noticed this, but with Zoom or Teams, you can connect via a link, or there's a phone call number that you can do. And so this is the same phone call that I make every single day, and it connects me to India, where Murali is. Now Murali was a scribe, so all I really need to do would be a Teams account, which my scribing company does. The one I use currently is IKS. They changed companies recently. It's called IKS, and they have a Teams repeating event on my calendar. I click that event. Actually, now it's just an autosave on the phone. I do it, and I don't use that phone for anything else. I recharge it every night. I put it in my backpack, and that's all I need. I need a phone, and I need a Teams account that they give me. That's really it. And then when I'm training him, I use the Teams video or the actual video to share my screen. So I have in my office, I use 7 computers. So 6 treatment rooms and then 1 in my office. And usually the one in my office is my base where I will come back. And when I was training Murali, I was sharing my screen, showing him how to do the notes, checking my notes with him. He could see me as I'm going through the notes. So in the beginning, it takes a little bit, especially since we just switched medical records. But that is all you need. Now, someone asked about, do I do like a written consent saying that they're there? No, but I introduce Murali to everyone. I don't do a written consent. I just say, hey, there is someone on this device, and I point to the phone in my pocket, and he is going to be taking notes for me. There are a couple of other methods that use video, and you would put an iPad, a small little mini iPad, and they can see things. The one that I use doesn't use visual. I think it takes a little bit more bandwidth to be on a video call, and I try to verbalize what I'm doing with the patients. And he gets used to it. He knows I talk about thickened toenails, and he learns now what I'm doing. And all the patients always ask me, is he AI? And I always say he's like 5 times a day. Murali is not AI. And for anyone that is Indian, his real name is Murli, but It took me about 6 months to learn how to pronounce Murali, and so I just call him Murali because I've been doing that for so long. And one day I actually tried to change and called him the right thing, and he said, "Why are you calling me by my real name?" I said, "Because I finally learned how to pronounce it." But he's my age. He is worried about his job because all of his colleagues there are losing their jobs because of AI. Now, I don't think AI can do what Murali can do. I do not think right now it can. I've talked about this before, but like for example today, I'm gonna record my day of a Thursday, but this is a Friday. We're gonna probably see 45 patients. He's gonna do all the notes. He's gonna remind me. He's gonna send prescriptions. He's gonna order PT. He's gonna review MRIs. He gets bogged behind, and he just kind of like catches up with me. So he's busy just doing notes, and I just sign off on him. So it makes it a lot easier for me. And I'm just at this point, I don't think AI is there. It might be there in the future. I think if you're doing AI for like an HPI, review of systems, discussion, I think things like that are okay. But currently, it's not quite there, and it is worth the investment. So the investment, for me anyway, is about $35,000 a year, and I think it's well spent. And I pay it. It kind of goes through the office, meaning, see, then it actually comes directly out of my salary, not even out of operating expenses, because I'm the only one that uses him, so it comes directly out of my salary. So it's worth it, in my opinion, for how much benefit I get from it. Okay, let's go into the day. First patient was Swift number 3 on the right foot. A 61-year-old man. I usually do 4 Swifts, so he's going to schedule 1 more in a month, and then I do a 3-month break. I am seeing improvement with the Swift. Next was a 33-year-old man with right plantar fasciitis, number 3 out of 6 for Shockwave. Next was a 56-year-old female. She had right Achilles insertional tendinitis. She got the Pelto special, night splint, foam rolling, morning stretch. The dynamic demonstration with I do a orb ball, and then I prescribed her meloxicam. I'm going to see her back in 3 weeks for possible ultrasound and shockwave, so she is aware of that. And next patient was a 40-year-old female. She had a K-reflex done on the right toenail, and she also had a wart, so we did lesion destruction on that wart. She didn't want cantharidin because it made her blister too much. That's why she didn't want cantharidin, so I just did salicylic acid. Next patient was a 68-year-old female with left heel pain, and she also had some midfoot pain. Last visit, I gave her 2 injections into the midfoot with cortisone, and she is totally better, so I'm not going to see her back unless that midfoot pain comes back. She already has orthotics. Next was a 70-year-old female, number 3 out of 6 for bilateral plantar fasciitis. She is going to start feeling better. I tell patients usually at the 5th visit. Next patient was 61-year-old female for Q-tenzin number 1, and we did that. I finally figured out the correct template, and I recently did on my YouTube page. I'm starting a ModMed kind of video series, the same thing I used to do with Athena, kind of sharing how to do different types of templates that are kind of challenging and different types of tips. So if you have any cool ModMed tips, tell me, or any questions. I'll try to figure them out because it was kind of a struggle, so I'm trying to make some resources on the Podiatry Practice Mastery YouTube page. Next was a 44-year-old male. He was here for only a nail evaluation. I've really never had this before. He had some like longitudinal lines in his nails, and he was concerned. And so his nails looked fine. But I really talked to him. He had some hallux limitus, so I talked to him about functional hallux limitus, gave him some information, and said that could just be hitting the top of the shoes. And I talked to him about the shoe liner test to make sure that they were big enough. He was actually pleased with the consult. I thought it was kind of a weird one. Next was a 50-year-old female for right plantar fasciitis. She did number 6 out of 6 shockwave. She is already feeling better. I'm going to see her back in 6 weeks. And I did an office visit. So always the last shockwave, I haven't talked about this for a while, so I have a last shockwave handout. So I give them that. It kind of prepares them for what's next. And so since I'm discussing about that, I think that is appropriate for an office visit. So once again, these are all within my treatment sheets that I use and I print out for patients. Next was Cutenza number 4. So this gentleman I made a little video on. 75-year-old man has neuropathy pain. Cutenza number 4. So the first two, he didn't feel anything. Third one, he's like, wow, all of a sudden my feet don't hurt. So if you're new to Cutenza or considering doing it, and this is what the reps say, it usually takes about 3 applications before they notice some improvement. And now he's like, wow, I can, like, my feet feel good. I can sleep. Everything else is fine. And he was like, how long is this going to last? And I said, I don't know, probably 3 months. That's why you do it every 3 months. So he is feeling better. Most of our Cutenza, so kind of a snafu about Cutenza. There are 2 ways you can do it. One is called buy and bill. That means we buy it for like an absurd amount of money. I think it's like $4,000. And then we bill the insurance that $4,000 and you make a little bit, maybe like 10%. The other option is you go through a specialty pharmacy and then they pay for it and then you just do the application fee. I prefer doing the application fee because you make, I don't know, maybe $400. I think it is $400 or $500 for the application. Real easy thing to do. The buy and bill, the problem is it messes up our billing. Not really messes it up, but like it's one of those things, just like when I used to do like Dermagraft. It's a high capital expense, and you have to cut that out of your production. So we did a 6-month review for the doctors, and I had like, I don't know, however much money I had produced, maybe, I don't know, $500,000 or $600,000. And so I had to take out like 50 of that or 40 of that because it was the buy and bill for the Cutenza. Just like, we don't really cut out other stuff from the doctors, but like these things that it's not really, it's just a cost. Like you buy it for $4,000, you earn $4,000. It's not, we just cut those things out. We don't do it for AFOs and everything else. We just do it basically for these high ticket items. So it kind of inflated my monthly number. So like when you see the numbers, I try to get 80 a month, 80,000 a month. That'll get to the $1 million. So some months it's 90, some it's 100, and so some of that shows it might be falsely inflated. Next patient was he had a 78-year-old man with a left 5th digit corn. Basically just had a hammer toe. I just talked to these ones about shoes, anatomic shoes, and I trimmed his little corn for him. Next was a little 2-year-old boy that kind of jumped off something and his feet hurt for a couple of days. They were concerned about a first metatarsal fracture. Got x-rays. At a 2-year-old, you can't really see much in the x-rays, but we got the x-rays. He went to the urgent care and they were still concerned. So they came and saw us. Everything looked fine. Next was a 72-year-old man with a left 5th MPJ pain. And I did an ultrasound. I saw some effusion around the joint. I did a cortisone injection, and I recommended him to have more of an anatomic shoe. I think it happened with his golf shoes that were a little too narrow, or some other type of shoe that didn't have any give on the side. So I did x-ray, ultrasound, and then the cortisone. He talked to me about, there is a golf shoe, if you need an anatomic golf shoe to recommend. I think it's called Squares shoe, and I looked, it's kind of a weird spelling with a Z, but if you need one to recommend, I have a shoe buying guide. That's how I tend to do it for my patients. Next was a 79-year-old female. My buddy, he had to go do a Liz Frank repair during lunch, and so I had to take over one of his routine. Morning is Thursdays, and so I did one of his nail care patients for him. Next was a 69-year-old female that I did a biopsy. She came in for like a skin lesion on the dorsolateral foot. I did 2 2-millimeter punch biopsies, and since I have to do a lecture on biopsies or dermatology here at a local conference, I took little pictures to show how easy it is. Basically, it should take like 1 minute, and if it takes longer, let me know. I'll try to help you out. Next was a 43-year-old female that had a wart with a cantharidin, and she is this. She's a runner. She's back to running because she had a tibant insertional issue going on, and she is getting better with Shockwave. Shockwave number 5 out of 6, basically no pain. I'm going to do one more, and then she should be fine. Next was a 56-year-old man, new patient, got a diabetic foot exam. He had a wart in the right heel as well. I did cantharidin on that, and he had a 1 thickened nail, so I did nail debridement and actually a nail sample for him. Next was a 68-year-old female for left anterior ankle, kind of a neuritis. She had a anterior ankle, she had like a ganglion, I think that popped and kind of adhered some of the tissues down there with kind of a nerve impingement kind of pain. And I'm doing Shockwave. She's on session number 2 out of 4. She's not really seeing much improvement yet, but we're doing that. Next was a 71-year-old man. he was post MRI. I was concerned for him. I did 2 injections to the first MPJ. He did not get better. On the MRI, we got an MRI because it wasn't getting better, and it was actually one of these, I don't know how you guys do it there, but it was like an orange alert, meaning they sent me like a text message, email, all from the MRI place. And it was because he had a stress fracture in the first metatarsal neck, and I'm not exactly sure what happened for that, but it's been painful for a while for him. So what we ended up doing is shockwave number 1 out of 4, focused only or non-radial only. This was the soft wave that we had in this office. And so I billed the fracture code. I dispensed him a cam boot. Actually, he had his own cam boot. And then I did number 1 out of 4. He's going to set those up. And usually I'm offering patients now, just so you know, with Shockwave, I'm saying, hey, most patients do it once a week. That's fine. If you want to kind of get them done faster, you can do them every 72 hours. So I do offer doing it twice a week for some patients. They just want to get it done faster versus like spreading it out. Next was a 78-year-old man after PT. He had some balance issues, and he's going to be getting orthotics. He forgot to pay for them, or we forgot to ask him for money. So didn't get his orthotics. He's going to be getting them. Next was a 44-year-old female, left second toe cyst. This was kind of interesting. She had a cyst in the proximal phalanx, probably maybe like an enchondroma. So I recommended that she get an MRI, and then we'll see kind of like offloading in a surgical shoe or a boot or something like that. Next was a left hallux, 70-year-old female that had a wavy left hallux that was kind of lytic and thickened. I took a nail sample for her. I don't think it's a fungus. I think it's an onycholytic nail that's kind of wavy because it's detached, and so I'm not going to see her back. I am going to call her with the results. And the last patient of the day was a 49-year-old female with left fourth met base fracture. She's number 3 out of 4 for non-radial only for that fracture. And we're going to get one on the next one in the 4th visit. We're going to get an x-ray, and then I usually do a 6-week follow-up. So she is doing well. So that was the day. Once again, I'm putting together a challenge. If you want to challenge yourself to get to the $1 million mark, I'd love to do it with a few people. I've had some people that are interested in the emails that are coming out. You should see them. If you don't get the email, shoot me one, don@podiatrypracticemastery.com. Looking for a few practices that want to kind of, if you're struggling, I know, like, it's hard to implement. That's the thing. I find, like, I talk about these ideas here. You might like them, but actually making change when you're in a busy practice is hard to do. That's why I put together this 6-month challenge, basically, so we can all challenge. I can be challenged, you can be challenged, and we're going to put together, like, it's a mastermind. So we're going to be a group of docs working together. So that's what I'm working on. If you're interested, let me know, and we'll talk to you more tomorrow.